Welcome everyone to today's live expert session on lupus and in vitro fertilization. We know that lupus and treatments for lupus can potentially affect how you approach fertility and your reproductive health overall, and this can be really challenging to navigate. We get so many questions about the subject, and while it can be different for everybody, it's really important to understand all the different elements and what the potential risks are and just what to consider when you're approaching fertility. So today we have Dr. Megan Lockwood with us to discuss lupus and reproductive health overall and to answer some of our top questions that you've been sending us via DMs about lupus and fertility. So thank you so much for joining us today, Dr. Lockwood. If you could just share a little bit about yourself with our community, that would be amazing. And then we can dive right in.
Absolutely. Well, thank you so much for having me here. I'm delighted to get to join you guys today. I'm joining you from Washington, D.C., actually. I'm a native Oregonian and West Coaster, but have made my way out to Washington, D.C., where I'm a rheumatologist and the director of the Lupus Program at MedStar Georgetown University Hospital and an assistant professor of medicine at Georgetown University. And so I'm just delighted to be here today to talk about lupus and reproductive health in general, and then we'll dive into a little bit about lupus and IVF. So I'd love to start by sharing some general overview with you guys, and then we can, spend some time answering some questions. Alrighty. So let's start a little bit by talking about pregnancy. Lupus is primarily a disease of women of childbearing age. So it is really important to always think about pregnancy and lupus. And a healthy pregnancy with lupus is possible, but lupus raises your risk for certain complications during pregnancy. So if you have lupus and you're planning to get pregnant, it's important that you work with your doctors to plan a healthy pregnancy. For a long time, people were told that young women with lupus should not get pregnant. But we know now that in the majority of cases of people with lupus, they can anticipate a safe pregnancy. If you have had really active kidney disease or you have a coexisting lung disease called pulmonary hypertension, then you may go on to have some very high risk pregnancy. But really, over 95% of people with lupus end up doing just fine. So the take home message should not be that for patients to say, oh my goodness, I shouldn't get pregnant. The take home message really should be that the best pregnancy is a planned pregnancy. And I should really talk with my provider about this so I can make sure that I get my disease under control and on safe medications before I get pregnant. These are the most common questions that I get from people when they're thinking about pregnancy. The number one thing people with lupus tend to want to know, or anybody who has a chronic illness, is whether their disease is going to flare during pregnancy. The second thing people typically want to know is what medication can I take safely during pregnancy? And then three, is the disease going to impact the pregnancy outcome? Does that mean I'm going to have a worse pregnancy outcome? So let's start with the first one. Will my disease flare with pregnancy? It is extremely important for people with lupus to be talking with their providers as they're anticipating pregnancy. And the thing we really want our patients to understand is that when they get pregnant, it really should be when their disease is under good control and when they're taking medications that they can safely continue during pregnancy. Because we know that if the disease is under good control when you get pregnant, then you are much more likely to have a good pregnancy outcome, both for the mom and the developing fetus. If you've had a history of kidney disease or if your disease is active at the time of conception, then there's a much greater risk of having a lupus flare during pregnancy than if you weren't pregnant. We really worry about the progression of kidney disease during pregnancy. And we always worry about the aggression of certain organ manifestations, such as kidney disease, when that happens. And we often have to treat people with higher doses of steroids and other strong immunosuppressive agents that can potentially be harmful for a developing fetus. So, what medications can I take during pregnancy? Part of why pregnancy planning is so important is that you will sometimes need to stop certain medications and switch to something that's pregnancy safe. And then you need to make sure that your body responds well to the new meds and that your lupus doesn't flare. This is a resource from the Lupus Foundation of America of a list of pregnancy compatible medications. I want to point out hydroxychloroquine is on here. It is incredibly safe to take during pregnancy. It has benefits both to mom and a developing fetus and can help to even prevent or reduce the risk of things like neonatal lupus in a newborn baby. This here is a list of medications that are generally not compatible with pregnancy. And again, this comes from the Lupus Foundation of America. Benlysta, we don't have great data as to whether it is or is not safe. There are some studies suggesting that perhaps it could be safe, but we generally try to avoid it if we can. Cyclophosphamide is a medication that we really try to not use during pregnancy, especially at time of conception. The exception to that would be if there's severe organ-threatening or life-threatening disease, and it might need to be used. Leflunomide, methotrexate, mycophenolate or Cellcept or Myfortic, we generally do not use during pregnancy. Thalidomide and lenalidomide, those are medications we don't use very often, but we really try to avoid those in pregnancy as well. And of course, rituximab, if you need the rituximab and you're stable on it, sometimes it can be continued through conception. And similar to cyclophosphamide, we really don't like to use it during pregnancy, but if needed, we can reach for it later on in pregnancy. In general, these are the medications that we will try to get you on and get your lupus stable on these meds before we want you to start trying to get pregnant. So will my disease affect the pregnancy outcome? You know, we really want to make sure that the lupus is quiet and that you are on meds that are safe for pregnancy. But even with improvements in management over the years, the risk of pregnancy-related complications are still increased in lupus pregnancies compared to the non-lupus population. Complications affecting pregnancy in women with lupus can include pregnancy loss, either early or late, premature babies with premature delivery, small for gestational age infants, so low birth weight babies, and lupus disease flares that can actually damage the mother's organs or very rarely be life-threatening. And then in people with lupus, there is just higher than average risks of other pregnancy-associated conditions, such as gestational hypertension, which means high blood pressure during pregnancy, preeclampsia, and that's a condition that affects some women during pregnancy where there's a combination of high blood pressure, protein in the urine, and in some cases, kidney or liver damage. And then eclampsia, where you can actually have seizures from that preeclampsia damage. You know, something that I really merits some special attention are the antiphospholipid antibodies. And I really try to empower all of my patients and really anybody with lupus to know your antiphospholipid antibody status. And these are really, you know, a nuanced conversation because these antibodies can be seen in people who have lupus, but they can also be seen in people who don't have lupus. These are antibodies that are associated with something called antiphospholipid syndrome. And that means that in some patients, it can contribute to things like blood clotting or an inclination to form blood clots. And in some patients can actually increase the risk of pregnancy loss, whether it's recurrent pregnancy loss in the first trimester or once you get into the second trimester. But you can have these antiphospholipid antibodies even if you don't have lupus and even if you don't have antiphospholipid syndrome. So it's really important to know your status, know what your antibodies are. And then it's also important to know that there is an increased risk of preeclampsia. So people with these antibodies and people who have lupus, it generally just adds more risk to the pregnancy. It's also important to know your Rho and Law antibody status. Rho and Law antibodies, or sometimes we call them SSA and SSB antibodies. These are antibodies that we see both in lupus and in Sjogren's. And again, just like the antiphospholipid antibodies, it's important to know that you can have these in your body even without Sjogren's or without lupus. And the reason this is so important is because there's an increased risk of something called neonatal lupus. So this is not the same thing as systemic lupus. You can't really give lupus to your baby. But when you have these antibodies, they can be passed to the baby, causing something called neonatal lupus. It does not mean that if they have it, that the baby will grow up and have lupus later in life. But the most common symptoms of neonatal lupus is a rash on the baby's face. That rash will usually go away within 6 months after birth or so, but rarely babies with neonatal lupus can get a condition called congenital heart block that can be identified during pregnancy. And when babies develop this congenital heart block, they usually require urgent care after birth and may even need a pacemaker to help control their heartbeat. So seeing a maternal fetal medicine specialist or a high-risk OB doctor during pregnancy becomes a very important part of a safe and healthy pregnancy and a safe and healthy baby. Birth control in lupus is another really important aspect of reproductive health care. And when I'm talking with any patient with lupus about birth control, the first thing I like to establish is, do you have the antiphospholipid antibodies? Again, know your status, because if you have those antiphospholipid antibodies, then categorically we avoid all estrogen-containing products. So that includes things like oral contraceptives. And there are some estrogen-only type birth controls that we really want to avoid. There are still options, though, like progesterone only containing birth control and IUDs. After knowing the antiphospholipid antibody status, then we want to think about people who've had more mild disease compared to people who've had more serious organ involvement. And those people with more mild disease can probably use any type of birth control they want, including low-dose combined estrogen oral contraceptives or the pill. That was shown in several studies in the early 2000s that people with well-controlled lupus on low-dose estrogen did not have an increased risk of flares. However, all of the people in those studies were antiphospholipid antibody negative. So in people who have had active disease in the past or have had renal disease before, kidney disease in particular, we really do not have any good data on whether or not they can use estrogen-containing birth control. So amongst those people, we generally recommend avoiding estrogen contraceptives altogether. It is also really important to point out, though, that the risk of actually having a clot and pregnancy without lupus or antiphospholipid antibodies is actually pretty high. So we really want to make sure that all of our patients have good contraception. This can get complicated really quickly. I want to share with you a great website. This is lupuspregnancy.org. This was put together by a really wonderful group at Duke in the Lupus program there. And this is a nice graphical representation of different contraceptive methods, how effective they are, and then how safe they are, thinking about in terms of blood clot risk, in terms of low lupus activity and high lupus activity. The ones that are really at the top here, I'm not sure if you can see my cursor, are the IUD in particular, is really what we like to reach for. But accidents happen. And emergency contraception, so the morning after pill, Plan B, and similar medications, these effectively prevent pregnancy if taken within 3 days of having sex. And I just want to reiterate the point that these are safe for all women with lupus, even those at high risk of blood clots. No prescription is needed for emergency contraception, and you can buy it from your local pharmacy or on Amazon. And importantly, emergency contraception does not cause an abortion. Your gynecologist will have other options for you for emergency contraception that can work up to 5 days after having sex. So with that in mind, I do want to shift and spend a few minutes talking about lupus and assisted reproductive technology. So, while medications, including cyclophosphamide, and just serious illness and kidney disease in general can make pregnancy more difficult, primary infertility rates, both in people with lupus and an antiphospholipid syndrome, are pretty similar to those in the general population. So we know, though, that fertility does decrease with age, and people, whether they have lupus or not, sometimes need to use these assisted reproductive technologies. So ART, assisted reproductive technologies, it refers to any fertility treatment in which either eggs or embryos are handled. So this includes things like ovarian stimulation, which elevates estrogen levels, in vitro fertilization, intrauterine insemination or IUI, and embryo transfer. Ovarian stimulation cycles for IVF generally require more aggressive stimulation than those for things like IUI. They involve surgical extraction of oocytes and with IVF followed by embryo transfer. I will note that frozen embryo transfer does not usually require ovarian stimulation. And these are a lot of terms to throw out. The most important thing is that you are working really closely with your rheumatologist, your lupus doctor, as well as your fertility specialist. And what I think is so important to understand is that it is possible and it is probably safe to do IVF and assisted reproductive technology in people with lupus. The data we have for ART, and more specifically for IVF, are very limited. And that's because most studies looking at ART really were not focusing on the maternal disease. But we do have more recent data, including one of the largest studies published last year that followed over 140 women with lupus who underwent ART, who had low disease activity, and generally found it to be safe and effective for women with lupus as the general population. So really promising news. What we do know from data on IVF cycles in people with lupus is that the attended outcome of IVF pregnancy can be adversely affected by the presence of active disease. So our general guidelines are that you should really have inactive or stable disease for at least 6 months on medications that are safe for pregnancy. But of course, there's always going to be individual clinical factors that can influence this decision. I do want to point out that there is a concern, a theoretical concern, that flares in people with lupus might be worsened in the setting of some of these procedures because of the elevated estrogen levels. However, this has never been confirmed in clinical studies. And at this time, we do not have any data to suggest that just empirically or proactively adding prednisone helps. And so generally, we recommend against that. Again, it really comes back to the importance of working closely with your rheumatologist and your fertility specialist to really determine the safety and timing of procedures. And again, this is really important in people with APS or antiphospholipid syndrome or people with antiphospholipid antibodies because ovarian stimulation does elevate estrogen levels and that can lead to an increased risk of clot. So it really goes back to knowing the importance of your APL status. I do want to spend just a minute talking about oocyte cryopreservation, or a fancy way of saying egg freezing. Embryo and oocyte egg freezing cryopreservation are both good options to preserve fertility in people whose condition is stable enough for them to undergo ovarian stimulation, but who are either not able or not ready to pursue pregnancy at the time of stimulation. And so I really want to talk with my patients when we're talking about reproductive health goals and family planning to understand that a carefully monitored ovarian stimulation or IVF cycle followed by embryo transfer to a surrogate is an option for people with more severe disease-related damage who desire a biologic child and are able to undergo ovarian stimulation and oocyte retrieval, but might not be able to safely undergo pregnancy. What I really want to point out is that if a patient is, or anybody with lupus is undergoing egg retrieval for egg freezing, so a procedure that does not result in pregnancy, you should still have very well-controlled lupus because of those elevated estrogen levels, but you don't necessarily need to take pregnancy-compatible medications. And this becomes really important for some of our patients who have more severe disease and cannot get off of CellCept, cannot get off of methotrexate. And so in general, we recommend continuing all necessary immunosuppressives and or biologic agents, except for cyclophosphamide, because that really does impact maturing follicles. But we recommend continuing those as long as your disease is stable, when the purpose of the ovarian stimulation is egg retrieval for freezing and not for pregnancy. So this includes continuing methotrexate and mycophenolate or Cellcept. But I would say there really are no published data that directly address egg retrieval during treatment with most immunosuppressives or biologic therapies other than cyclophosphamide. So we often focus on women because 9 out of 10 people with lupus are born female. However, 1 in 10 people diagnosed with lupus are born male, and it's easy for us to kind of forget about that in our reproductive health conversations. We're trying to get better at recognizing the importance of this, but I do want to spend just a moment talking about it. We know that during the time of great disease activity from any disease, there will be reduced fertility. However, once the lupus is under good control, then the next question becomes, what medicine is it safe for men to stay on at the time of contraception? So for men who are having female partners and ongoing vaginal intercourse, how will that affect fertility? We know that methotrexate is not safe for women to be on when they get pregnant, but what about men? It turns out that methotrexate is really not an issue for men and fertility. There's really only 3 medications that we worry about. So first is cyclophosphamide, which can cause both permanent infertility and potentially cause congenital abnormalities. So sperm banking should be strongly considered before starting cyclophosphamide so you don't get permanent low levels of sperm, making it so that you can't conceive. Thalidomide is another medication that we suggest men stop, not because of the fertility issues, but because there is a very, very, very small concentration of glutamate in the semen. And because of that, there's a potential teratogenic risk, so risk to developing fetus. This is a medication that we use very infrequently these days. It's usually reserved for people with very severe skin disease. The last medication that we worry about is sulfasalazine, which can cause some patients to have a lower sperm count. So we don't typically stop this medication up front unless the patient is having trouble with conceiving. And then we'll typically recommend a semen analysis. But these are really the only drugs that we worry about too much. The reality is that medications taken by men once their partner is pregnant really do not get concentrated in the semen enough to really impact what's being absorbed vaginally by the woman that would then hypothetically go on to impact a developing fetus. So, people can feel really sensitive or even embarrassed when they talk to their doctor about these topics. As clinicians, we're trained to be good listeners who are not judgmental. Our job is to help people. That is why we went into medicine. As providers, we have heard everything and anything. And I understand I've been a patient that, you can feel uncomfortable, but I promise as a physician, it's not the first time that we're hearing it. It really is your duty to yourself and your focus on your health. And you can't do that unless you feel open and comfortable discussing, all sorts of things with your provider. And high on that list is reproductive choices, sexuality, sexual function, contraception. And hopefully as physicians, we're doing our job by asking some of these questions in an open-ended way that helps you to feel comfortable. We want you to be your best self and your healthiest self. And if you're open and share that stuff with your providers, then you're going to be able to do that. I think it's really important to remember that sexuality and fertility and reproductive health are all an important part of having a good quality of life, which is what every doctor wants for their patient. And so it's really an important part of self-care. And I really empower you to talk to your doctors about these things. So I think with that, I'll wrap up there. And I'm more than happy to, take any questions or start any conversations.
Great. Thank you so much for your time, Dr. Lockwood. And that was a really awesome sentiment. Not everybody feels empowered to have those conversations with their doctor, but you have to start somewhere. So thank you for all of this information, because a lot of it was great for jumping off. We do have questions. I'll just dive right in. So one of the first ones submitted via DM is, do the hormones from IVF increase your risk of a blood clot with lupus? If so, how much higher is the risk? And I know you covered a little bit of this in your deck.
Yeah. So, that's something that I think we have been told for a long time, but it is really what it has not been significantly borne out in the data in people who are negative for antiphospholipid antibodies. And that's the really important thing here, is knowing your status. Lupus itself is associated with a slightly increased risk of blood clot.
Yeah.
And when you go on these hormonal medications, in theory, there would be that kind of increased risk. But it really hasn't been borne out in studies. And we've really found, in several studies, like older studies that have focused on lupus and APS, that neither lupus flare nor blood clot are occurring more frequently. There are other risks, such as ovarian hyperstimulation, prematurity, emotional distress, all of these things. But clot itself in people who have well-controlled lupus and are APL negative, that's not, that concern hasn't been borne out in the data. However, it's a very different conversation if you do have antiphospholipid antibodies.
Okay. Yeah, that was an interesting distinction that you made in your presentation. Um, and I know that you touched a little bit on like remission and disease control versus being in a flare when conceiving, but someone asked, do you have to be in remission for IVF to be safe? And if yes, how long do you have to be in remission for?
Yeah, it's a great question. In general, 6 months is what we want. That the studies really show that if your disease, if the lupus has been quiet, inactive for 6 months, that's really probably the best and safest time, both for you and your baby to get pregnant. And I would say, as I tried to highlight earlier, that's really 6 months on pregnancy safe medicines. And so you can imagine how that actually can turn into a little bit longer if you're on medicines that are not pregnancy safe. So if you're on Cellcept or you're on methotrexate, if you have lupus nephritis, you're on blood pressure medicines, you've got to switch those medicines. And then your lupus has to, respond to that and remain in remission for 6 months, ideally, before you'd start a procedure.
Yeah, that's an important caveat. Definitely makes the journey a little bit longer.
Does. It certainly can. So all the more reason to start having these conversations with your providers, years in advance. I try to ask all of my patients, what are your plans? Are you thinking about getting pregnant in the next year? What are you interested in family planning? Is that something that's 5 years down the road? Because if we can switch their medications earlier, even before they're kind of thinking about it, but not active on it yet, then maybe that's the time to do it. So you're not feeling that kind of pressure.
Yeah, like the runway is too short.
Yeah.
Okay. Someone else asked, what will happen if you have a flare up during the processes of IVF, and will you have to stop IVF?
That's a great question. And it really, there's a lot of individual factors that go into it. I think the short answer is you'll probably have to put it on hold until you can get your lupus under control. Um, but it doesn't necessarily mean that you can't go back to it. It also depends on the kind of flare you're having, what organs are affected, if any, what medications it will require to get it under control. But generally, you really don't want to go through a procedure like that. At the very least, the cost of a procedure like that, knowing that the chances of success are going to be so much lower if you're actively flaring.
Yeah,
The
definitely.
physical and economical, financial cost, not
Yeah,
mental cost.
definitely a lot to consider.
Yeah.
Based on what you shared with us in your presentation about the lack of data, I have a feeling that I know the answer to this question, but someone said, is IVF more or less effective in women with lupus? Do we know anything about the actual effectiveness of IVF in women with lupus?
That's a great question. So my understanding of this is that there does not seem to be a decreased efficacy of IVF in people with lupus. And
Okay.
I will even go one step further to say that the presence of antiphospholipid antibodies have really not found an association between the antibodies and the number of IVF cycles or fertility success rates. I mean, the data for this are really limited. So we're not talking like high quality randomized control trials, but in general, I think the answer is no.
Wow. Okay. And then this is a more general question, but it says, can you do IVF with any autoimmune disease? Do you have like a sense for if the data is just different for everybody, or if it's kind of a similar rule of thumb around being in remission for whatever your autoimmune disease is?
Yeah, for rheumatic diseases, so those aren't all autoimmune diseases, but a lot like rheumatoid arthritis, ankylosing spondylitis, mixed connective tissue disease. Our rule of thumb really is like 3 to 6 months of, totally quiet disease activity and then thinking about pregnancy. And so I don't think I could speak to all autoimmune diseases, but I would imagine in general, that's probably a pretty similar rule of thumb. Because we know that when you're sick, when any disease is active, whether it's an autoimmune disease or not, your body's under stress. And so it's not going to be able to do those things. It's not going to be in its healthiest state to be able to kind of get pregnant and be ready for those things.
Sure.
We know that when people are in periods of stress, the fertility decreases, whether that's stress from an illness, whether that's physical stress. We know that in gymnasts, menstruation changes or with any type of intense physical activity. And so those, stress is stress to your body.
Yeah, that's a really important point. The next question that we have, let's see here. Does lupus affect egg quality?
That's a really good question. My understanding is that no, it does not.
Okay.
Understanding. I don't think we have really great studies that have looked at that, but in general, we don't think that lupus itself affects fertility, which includes egg quality and egg quantity. The number that changes if you've been exposed to cyclophosphamide before, because that can substantially reduce egg quantity.
Okay, noted. And then our last question here is specifically about, 1 second. Our last question here is about the medications, but I think that you already covered this one and about IVF being safe with medications. So we'll just refer back to that chart that you shared. And then someone else asked, is lupus always considered a high-risk pregnancy?
The short answer to that is yes. Lupus is considered a high-risk pregnancy. There are just inherent risks to having any chronic disease. It does not mean that it's not safe to get pregnant, and it doesn't mean you can't get pregnant. And over 95% of people with lupus are able to go on and have a successful pregnancy. So it's a higher risk pregnancy. It's really important that you follow really closely with your obstetrician and then your MFM, which is like your high risk obstetrician and your rheumatologist. And everybody works really closely together to monitor your health and your baby's health.
Okay. Thank you so much for your time, Dr. Lockwood. Those were awesome answers, and we're really glad to have you here today. If anyone wants to learn more about you and your practice, where should we send them?
Oh, where should you send them? I guess we have, we're always, if you're in the DMV area, we're always delighted to see you and talk about clinical trials, reproductive health and lupus. You can find us at Georgetown University Hospital, MedStar Georgetown University Hospital. You can just find us online.
Nice. And just note for the community, we have these live sessions with experts fairly often about different topics that you request and experts that you want access to. And if you want to be notified about any events upcoming or anything that we have going on, we'll drop a link in the comments so you can join our community via email and get notified in advance. Thank you so much, Dr. Lockwood.
Yeah, thank you so much too. Those are really great questions.
I just stopped the live stream and I'll